the main focus of today's stream was that we were just going to be playing Doctordle. Doctordle is not perfect, right? I mean, they try to write it like board questions, but you know, something like this: 50-year-old man presents with a blood pressure recheck visit with no acute complaints. Like, how am I supposed to know what the diagnosis is, right? Like, it's not perfect, but I don't know. I guess from a lot of the comments, like, people just liked hearing me yap about like my thought process and stuff. So 50-year-old man presents for a blood pressure recheck visit with no acute complaints. I mean, it's wait, is it primary hypertension? There's no way. Guys, I was in the top 50% players today. All right, so this is literally just high blood pressure, right? Like, the first like 2 clues just tell you that there's like nothing wrong with him. The third clue says he works long hours as a software developer, eats fast food for most meals, and rarely exercises. Fourth one says BP shows 150/95 from previous visit of 152/96. This is when you want to make sure that you're getting 2 separate readings, and lab studies are showing that nothing is wrong with his kidneys. He's got no electrolyte derangements, his urine is normal, and it's not messing with his heart at all. Further lab studies showing aldosterone and renin within normal limits. This is telling you that the renin, angiotensin, aldosterone axis is functioning fine. He's got no problems in the juxtaglomerular space or with the actual secretion of aldosterone from the adrenal glands. And, you know, kidneys are still functioning. Blood pressure is not due to like a tumor independently producing things like, I don't know, Conn syndrome. Seeing how the TTE shows no coarctation of the aorta means that the aorta, which is the largest artery in the body that is responsible for receiving all of the blood that's being pumped out of the heart and distributing it through the entire network of blood vessels in your body. Coarctation is a narrowing, which also kind of falls in the same vein as aortic stenosis in 2 different ways, but it's basically saying that his TTE is completely benign and he doesn't have any physical abnormalities like narrowing or stricture that would cause, you know, a reason to have increased blood pressure. A 42-year-old woman presents to her primary care physician with complaints of poor sleep and difficulty concentrating at work. This can literally be anything, right? I mean, when you think about it, right, like sleep apnea, that's a great one, right? Because if people have poor sleep, right, they're not getting enough oxygen in their brain while they're sleeping, they're constantly, you know, having apneic episodes, they're constantly waking up at night, poor sleep, and you're going to have difficulty concentrating at work no matter what if you can't sleep, right? So, I mean, yeah, does anyone else have a different, you know, differential, right? So we're thinking insomnia, right? It could be a primary insomnia, paroxysmal nocturnal dyspnea. That's a good one. You see that a lot in heart failure or with certain anemias. But yeah, this is all pretty generic. We can just say insomnia. Okay, I guess insomnia is not an answer choice. What were the other ones? Depression is a good one. Let's say sleep apnea, right? So sleep apnea. So there are 2 types, right? There's central sleep apnea and obstructive sleep apnea. So obstructive sleep apnea, you usually see when somebody has a very obstructed airway, either because of like neck circumference, like when they're overweight, or because they have gigantic tonsils. And when you're sleeping on your back, your airway collapses and impedes, you know, the flow of air, blocks the oxygen going to your brain, and you wake up. Central sleep apnea is you have a problem with your brain stimulating you to breathe when you're asleep because, you know, it just forgets to work. So common things being common, we can put down OSA. That's fine. She attributes her symptoms to just stress and avoids discussing specific triggers. So, you know, we're not really getting a lot here, right? So poor sleep, difficulty concentrating, and we're just getting negatives here, right? So she doesn't really think there's a big problem going on. She can't really narrow down anything, and she avoids discussing specific triggers. I'm not really sure if that means she avoids discussing her triggers, like she has triggers, or does that mean like she doesn't have any triggers, right? Like if she avoids discussing triggers, that's PTSD, right? Or yeah, anxiety or something. I don't like how this is worded. Avoids discussing specific triggers. So like, right, so let's say it's like PTSD, right? Like maybe she was like, I don't know, in a car accident, right? And she's got PTSD from that. And I was trying to make small talk and I was like, what's your favorite kind of car, right? And she avoided answering the question. Like, is that avoids discussing specific triggers? Like, I don't know. Let's just say PTSD. Let's just make it simple. Oh, okay. Should be okay. I love that it was actually about cars too. Yeah, I feel like this was Look, guys, I swear they get more interesting, all right? Like the first two ended up just being primary hypertension and post-traumatic stress disorder. Like they're not always that simple. We will end up learning more interesting things, I promise. You know, avoiding discussing specific triggers. I mean, obviously, for PTSD, there is something called cognitive behavioral therapy, right? And for psychiatry, this is where people really get the most help, right? Medications do help with, you know, PTSD, with depression, right? You know, prescribing SSRIs, like, you know, Prozac, Lexapro, these sorts of things, like these help patients, right? But as an internal medicine doctor, this is not a psychiatrist speaking. Like, I really think like therapy is actually how you actually learn these strategies and coping mechanisms and these sorts of things. So in my, you know, experience and in my capacity as a medicine doctor, right, I would make the diagnosis of PTSD. I would try to start them on an SSRI or something, right? I don't know what a right one is, right? Like if it's Lexapro, if it's Paxil, if it's whatever. You know, eventually I would refer them to psychiatry and get them, you know, enrolled in these sorts of things. A 23-year-old man presents with visual hallucinations and altered perception. Okay, well, I guess we're back in the realm of psychiatry right now. I mean, we've got like schizophrenia, right? I mean, visual hallucinations is like a positive symptom of schizophrenia because it's something that's added to their, you know, symptoms, right? Versus negative symptoms of schizophrenia, which is like flat affect, being withdrawn. So schizophrenia, schizoid, schizophreniform, these all actually refer to different diseases, all right? So you have a schizotypal, you also have a schizoid personality, you also have schizophreniform, which is like 6 months or like fewer than 6 months of schizophrenia symptoms, and then you have like schizophrenia. Intoxication, usually you wouldn't see visual hallucinations with intoxication though. ERP is exposure and response therapy, BTW. Yeah, I think that the psychiatry board review stream I did with Lev, she told me there exists a combination therapy called CBT ERP, all right? And I'll let you guys grapple with the consequences of what that could be. So I'm gonna put down schizophrenia. I like schizophrenia. He describes seeing trails while following moving objects and feeling like time is distorted. Whoa, okay. So when you start to think about these things, it's also just like, is this going to be a medical issue or a psychiatric issue, right? So trails while following moving objects, like that can be, yeah, so that could be like something in the brain, like a neurosymptom, like migraines. It could be intoxication. It could be like an oculomotor problem, right? And then feeling like time is disordered. Like, what does that mean? Like, he feels like time moves slower. Like, yeah, like depersonalization. Like, what is our symptom here, right? What system are we dealing with? This is actually why, you know, somebody asked me at the beginning of the stream, like, what do you enjoy about rheumatology so much? Like, this is the kind of stuff, right? So like conditions like lupus, you know, they're called the great mimicker because lupus affects so many different body systems and can be so many different things. So a good diagnostician knows exactly how to hone in on what those things are and say like, hey, this is not necessarily like a kidney issue. This is lupus nephritis. And if we treat the lupus, your kidneys will get better. Or like, this is not a pericardial issue. Like this is, you know, lupus causing serositis and recurrent pericardial effusions. Like you don't need a heart transplant. We just need to treat the lupus, right? So that's kind of a cool part of my job. Schizotypal. Yeah. So, I mean, now it's just, okay, before I rule out psychiatric disorders, it's important to know what the timeline is for these symptoms. A lot of Doctordle questions like these, the way that they're written, I mean, they'll give you one sentence at a time. In a real like board review question, they would actually give you like all of the symptoms, the timeline, the positive, negative things. So it actually helps you. So they would probably give you all 6 sentences at once. But that's why Doctordle is a game. Right? Like we're trying to get the diagnosis in as few guesses as possible. So even if we don't have all the information, we might as well just throw things out there. Time is distorted is making me think of like intoxication by substance or something else, because that's usually not like a normal, you know, not like a normal psychiatric symptom. You know, like this is, now we're kind of getting into like a neuro sort of realm. And then trails while following moving objects also kind of feels like, should we be worried about like a oculo issue? I don't know. Do we have like psychedelic stuff here? Primary psychogenic postpartum psychosis, antipsychotic induced. Nah, we don't. We could call it brief psychotic disorder. I don't know. Should we go down just like the rest of the schizophrenia? So we have schizoaffective, which I believe is schizophrenia plus bipolar. We have schizoid, which is a personality disorder. We have schizotypal, which is a personality disorder, and we have schizophreniform disorder, which is schizophrenia just on a shorter time scale. The question really doesn't give enough, time frame things, so I feel like we'd have to just keep ruling them out. Okay. Oh, okay. Physical exam reveals dilated pupils and mild tachycardia, but he is oriented to person in place. Now we're actually in a place where we're actually thinking about drugs, right? So we're thinking dilated pupils, mild tachycardia. Are we someone says mushrooms. I know from experience. I mean, if you know from experience, I mean, who am I to say? Substance induced? Yeah, let's go substance induced. So there's substance use disorder. Oh. So we have substance use disorder. Do we have mushrooms? No. LSD. Ooh, okay. So we specifically have LSD. Substance use disorder, LSD. I mean, it could be Molly. All right, LSD intoxication. Yay, we did it. Okay, so yeah, he has episodes of anxiety and describes colors appearing more vivid than usual. So this is where you're actually, getting there. Psilocybin, ooh, that's a good one too. But yeah, I don't think substance use disorder considering they came in. Yeah. So this is the thing, like when we're thinking about time frame, like his symptoms resolve without intervention after several hours under observation. Like, okay, this is where we're actually talking about, like, this is an acute, intoxication kind of thing. And then episodes of anxiety and describing colors as appearing more vivid than usual, and that's probably where you're taking a hallucinogen. So yeah, and the last clue just says he took acid. So this is another thing too, like you should, as a doctor, end up getting familiar with street names for drugs, right? Like you should know the difference between crack cocaine and, like, you should know what freebasing is. You should know, like how people take drugs, because your patients will talk to you like that. Like your patients will not tell you, straightforwardly what they're injecting, where, how. Like learning a common language with your patient helps you understand what they're doing. And it also helps them open up to you because they're seeing you as somebody who actually cares enough to ask, right? You don't just say, oh, do you smoke? Do you drink? Do you do drugs? Right? Like it is the most easy way for a patient to just be like, no, not really, sometimes, right? And it technically answers the questions, but in reality, you're not getting any good information, good actionable information out of that, right? So just talk to somebody, right? Just learn what they do, all right, and take care of them. Not that hard. 62-year-old man is brought in by his wife, who is concerned that he's been forgetful since a recent hospitalization. So we see this all the time, especially in more elderly patients, right? Being hospitalized sucks. I don't know if you guys have ever been, admitted overnight in a hospital, right? There's so many things that goes on there, right? You've got nurses coming in, you've got, techs drawing your blood, right? Literally stealing your blood, okay? You got the case manager trying to come in, talk to you about your insurance, and your body feels like crap. You've got a fever, you're sweating through your bed sheets. You got a med student coming in at 5 a.m, asking if you pooped already, right? So you're not getting good sleep, right? You're going to forget what time it is. You're going to forget what day it is. And as you get older, these things really mess you up. Outside of whatever medical condition you're dealing with, the fact that you just get so disoriented over your hospitalization does a number to people. So dementia, like after broken hip, yeah. So the reason why that's so bad too is because it's not necessarily the operative repair that's a problem for people. It's the problem for people that are just staying in bed all day and they forget these sorts of things and they get so disoriented, they get so delirious that they like forget to do things and they just don't recover well. Imagine being bothered every 4 hours for vital signs overnight and being confined to a hospital bed. Is delirium even a thing? Delirium, hospital acquired delirium. Incorrect. Okay. He is alert and oriented, but repeatedly asks the same questions during the interview. So it kind of depends on what the reason hospitalization for as well, but hospital-acquired affections are also a thing. So HAIs, you know, they're tracked on like a state and federal level by the Department of Health, right? You can catch things in the hospital too, right? Like if I admit you for a UTI and treat your UTI, there's nothing in there that says you couldn't get a pneumonia while on the floor also, right? You can be in a hospital, you can catch COVID, right? We wash our hands, we sanitize, we do as much as we can, but hospitals are nasty places with germs everywhere, right? So you're always at risk of, you know, catching something as you're there. Alzheimer's, dementia, since hospitalizations can make dementia worse. That's true. So if you're there for a recent hospitalization and you were there for X amount of time and you had some sort of metabolic stressor that uncovered, you know, something going on, right? So maybe he was going to develop dementia by the time that he was 65, but, you know, he had a really bad fall. He was hospitalized for a week and a half and he has a reduced baseline. Like that can definitely unmask stuff going on. So, ooh. Let's say Alzheimer's disease? No, okay. He appears unaware of his memory deficits and becomes frustrated when corrected. Let's see. He's unaware of his memory deficits and becomes frustrated when corrected. So he's still lucid. It's just that he's not when he's being asked the same questions during the interview, huh? Okay. Interrogated? Oh. He repeatedly asks the same questions during the interview. So he's having interrogate amnesia? Huh. Damn. Wait, I completely glossed over that. Wait, he repeatedly asks the same questions during the interview. So that means when he's talking, he's like, oh, but like, what time is it? And then you'll say like 4:30, and he's like, okay. And then like you'll talk for another 5 minutes, and then it'll be like, but also, what time is it? And then you'll say like 4:30. Like I just said it was 4:30, and I'll be like, oh, okay. And then you do like a memory test, and he's like, I don't know, nothing's wrong with me. And then you correct him, and he's like, that's what I said, right? And then he'll be like, hey, what time is it? Like it's 4:30. Okay, wow, that was actually pretty good because I completely skipped over what this meant, right? So for board questions, obviously it's a lot more obvious when you're talking to a human being and stuff, but like board questions and by extension Doctordle, like these sorts of things, like all of these small details really add up. Like this is why you got to read the question like 2 or 3 times. This is why like all of the board exams like UWorld or the actual test itself have like highlighting functions, because like small little tidbits like this really help you get the answer.